On behalf of the Patient Safety Authority, I would like to welcome you to this webinar titled Antibiotic Stewardship Webinar Series, Clinical Decision Making. My name is Amanda Bennett, and I will be your moderator for this program. All materials are provided for your educational use. Now, I'd like to introduce our speaker for the webinar. Joanne Adkins is a registered nurse and infection prevention advisor for the Patient Safety Authority. Ms. Adkins is board certified in infection control and epidemiology and is a fellow of the Association for Professionals in Infection Control and Epidemiology. Ms. Adkins is a 2019 recipient of APIC's Heroes of Infection Prevention Award for Education. She is a member of the Association for Professionals in Infection Control and Prevention and has served on the Member Services Committee, the Sigma Theta Tau International Nursing Honor Society, and the Pennsylvania Association Directors of Nursing Administration Long-Term Care. Joanne, I will now turn the program over to you.
Thank you, Amanda. Welcome everyone to the 8th webinar in our series. Next month will be the final webinar in our antimicrobial stewardship series that Amanda will be presenting, so I hope you can join us. Today we're going to discuss clinical decision making. Choosing to start an antimicrobial is a decision that is not to be taken lightly or be uninformed. There are broad interventions available to improve antibiotic use. Standardized practices should be applied during the care of any resident suspected of an infection or started on an antibiotic. These practices include improving the evaluation and communication of clinical signs and symptoms when a resident is first suspected of having an infection, optimizing the use of diagnostic testing, and implementing an antibiotic review process for all antibiotics prescribed within your facility. So our objectives for today is to describe the roles staff have in the decision-making process for starting an antibiotic, discuss the differences between the Loeb and the revised McGeer criteria, and review tools and resources available to assist in determining if a resident has an infection. So there are 5 key pieces to appropriate antimicrobial management. Accurate identification. Are staff following criteria to determine if a culture is needed? Do they even know the criteria? Have your staff received education on what is appropriate signs and symptoms? Second one is appropriate treatment. Is the empiric therapy initially ordered based on your facility antibiogram? Do you have a timeout protocol in place within your facility to review culture results in antibiotics with the prescribers? Review of data is the third one, and are you reviewing your monthly data results with key stakeholders? Is data, not only infection, but antibiotic usage, reviewed at your infection prevention committee and your QAPI committees? Education. Has education been provided not only to your staff, but also to your providers, your residents, and your families on antimicrobial stewardship? And is this education reinforced and routinely provided? And then review of infections. When an infection occurs, is it reviewed at your infection prevention committee and your antibiotic stewardship committee? Because you should be drilling down on the infections that occur. So how do we determine an infection? Well, it's a multi-step process through symptoms, through testing, and through the application of criteria. And we have 2 separate criteria we're going to discuss, the Loeb criteria and the revised McGeer criteria. So when we're talking signs and symptoms, there are key points in defining infections in the elderly. If a healthcare-acquired infection is a localized or systemic condition that was not present or incubating at the time of admission to your facility, any signs and symptoms of an infection must be acute, new, or rapidly worsening. Non-infectious causes should always be considered before it is determined to be an actual infection. And make sure staff is educated on the definitions for constitutional criteria, because this sometimes really is a gray area that muddies the waters when thinking of an infection. Do staff know the standardized terminology of what criteria constitutes a fever? And that's a fever over 100 or a fever that is 2 degrees above that resident's baseline. Do they know the actual definition for a new onset confusion or for a new onset of functional decline? Just because someone is not quite themselves that morning or maybe they fell does not mean that an infection is present. There could be other causes. And the criteria very clearly defines what needs to be in place to claim a new onset confusion or a new onset functional decline. Do staff know what leukocytosis is and what the white count needs to be? And do they know when they're doing an assessment to look for suprapubic pain or costrovertebral angle pain if we're talking UTIs, and what areas of the body they're even looking at? All of these things play into diagnosing an infection. And then testing. As I always say, garbage in, garbage out. Staff need to know how to properly collect and transport specimens. Make sure the value of a culture is compromised or even negated if the specimen has not been properly collected, handled, and stored. Make sure they're doing hand hygiene before and after specimen collection. And make sure somebody's evaluating to see if the resident is capable of participating in collecting that specimen. It's very easy to order a urine for culture and sensitivity and go to do a clean catch, but if you have a patient with severe dementia, can they actually assist in collecting a clean catch urine? Make sure all specimens are collected in sterile containers with close-fitting lids. That avoids contamination and spillage both. And it's vital that specimens are collected and cultures are done before starting any antibiotic. Once an antimicrobial or antibiotic has started, your microflora change, and that could lead to a potentially misleading result. So these are all key points when it comes to determining an infection. And then the third part is the application of criteria. We have two separate criterias. Clinical criteria is used by providers to inform decisions when care is needed, and it takes into account resident factors like indwelling catheters or central lines. Surveillance criteria is retrospective, and it is used to account actual true infection cases and to estimate the actual incidence or prevalence of disease conditions within your facility. Clinical criteria take into account patient factors, and they're important because we treat patients, and sometimes that treatment, that's criteria, and those clinical decisions are made before we have the actual diagnostic test results. So the first is the clinical criteria. This is the Loeb criteria. They are a minimum set of signs and symptoms which, when met, indicate that a resident may likely have an infection and that an antibiotic might be indicated, even if the infection has not yet been confirmed by diagnostic testing. When the criteria is met, there's a reasonable expectation that the resident has an infection. However, this criteria does err on the side of caution, leading at times to treatment for infections that are not confirmed. For this reason, we don't use this criteria retrospectively to look for true infection. What this criteria does is it summarizes the information available at that point in time to the prescriber when making initial treatment decisions. This is when you have a resident who has signs and symptoms. They're running a fever. They're having some other symptoms. Maybe they're having costrovertebral tenderness. Is it a good possibility they have a urinary tract infection? Yes. So this slope criteria is a way to guide a prescriber through that, to order the cultures and then start the antibiotics. The McGear criteria, on the other hand, which most of you are familiar with, which is what we base the PACERS reporting on, is surveillance criteria. It's used for counting true infections. This is what levels the playing field. Now, as we know with any criteria, sometimes you will have a resident who actually has an infection but does not meet the criteria, so it will not get reported into PACERS. Or you may have a resident who meets the signs and symptoms that would then require reporting into PACERS, but it may not have been a true infection. And what I'm thinking of there is the lower respiratory tract infections that do meet the criteria for a lower respiratory tract infection, but there is a possibility it could be CHF. But the McGear guidelines are applied based on the testing results that are available and the signs and symptoms. The criteria is specifically designed to remove the subjectivity and ensure an accurate, reproducible surveillance data for your facility. So I want to ask you a polling question here, and Shelley, would you please open the question? For those of you on the webinar, what's your biggest challenge in identifying an infection? Documentation that does not note the resident's symptoms? You're not notified of a culture or testing being performed or a change in a resident's condition? Or you have difficulty applying the criteria? So please take a few seconds here to vote on what is your biggest challenge. This information helps us as the IPs here at the authority. If documentation doesn't note the resident's symptoms, then maybe education needs to be provided to your staff on the importance of documenting any potential signs or symptoms. If you're not notified of culture or testing being performed or a change in the resident's condition, then that's another educational piece to discuss with your staff and why it's important that you know that. It's nice to know that the resident's condition is changing and a culture was sent so that you can be proactive and start to look for the signs and symptoms. Or if you're very new as an IP and the criteria can be confusing at times, and I remember that from many years ago when I started in infection prevention, please contact myself or one of my two coworkers here, and we can help explain the criteria with you and walk you through a case you may be having. So please take a couple seconds here to vote. And then Shelley, I'll ask you to close the poll here in a couple seconds. Okay. Do we have results on the poll, Shelley? Because I'm not seeing them.
Yes, we do. So it looks like we have documentation does not note the resident symptoms as having the most feedback. And then second would be not notified of a culture or testing being performed or a change in a resident's condition. That came in with 10%. And then lastly, difficulty applying the criteria with 7%.
Okay. When it comes to documentation, you know, as nurses, we live and die by what we document and by our policies and procedures. My suggestion for you as IPs would be to work with your director of nursing or your clinical nurse educator to provide education on the importance of documenting the signs and symptoms. And then also provide education to your staff on what are appropriate signs and symptoms, so that we're not just sending cultures off based on the fact that urine was foul smelling or was cloudy. So to help you with all of this, the AHRQ, the Association for Healthcare Research and Quality, has a wonderful toolkit called the 4 Moments of Antibiotic Decision Making. The 4 moments of antibiotic decision making are the critical time periods when the decision is made to either start an antibiotic or review therapy. Frontline staff and your prescribing clinicians are encouraged to use this framework for all residents whenever the need for antibiotics is being considered and for those who receive antibiotics. So the 4 moments are listed on the screen, and we're going to discuss each of those 4 moments a little further. Moment 1 is make the diagnosis. Does the resident have symptoms that suggest an infection? This moment occurs when the resident is assessed for a change in status and there is a concern that an infection may be started. Many times, long-term care staff recognize that something is not quite right with the resident, but aren't clear on what is wrong. Nothing beats a good assessment of that resident. And the person doing the assessment should pause and consider if the changes they are noticing really suggest an infection or there is another cause. So if you notice changes in your resident and you think they may have an infection, a good assessment should be done. That will give you the information to see what signs and symptoms are actually there. And then it is vital that those signs and symptoms are documented. Do they have a fever? Is it over 100 or is it 2 points above baseline? Do they have a productive cough? Severe acute new onset dysuria? If we're looking at cellulitis, do they have purulent drainage or very warm red skin? Once the signs and symptoms are noted on assessment, then you need to clearly communicate them with the provider. And we always go for clear, concise communication, and an SBAR is one of the easiest ways to make that happen. Moment 2 occurs immediately after the decision is made to start an antibiotic. With moment 2, what you're looking at is what type of infection is suspected or you think the resident has. Appropriate cultures are ordered. The symptoms are documented. And make sure staff is competent on how to collect the culture. There's nothing worse than somebody doing a throat culture for a suspected strep throat and they only get oral flora back because it was just saliva. I strongly encourage you to consider with your nurse educator on doing competencies for your staff on appropriate collection of specimens. Specimens have been collected, the cultures have been sent, the symptoms are documented. Then what empiric antibiotic therapy should be started? The prescriber should follow your antibiogram for your facility and choose an antibiotic that covers the most likely pathogens. You base your empiric therapy on most likely pathogens following your antibiogram. And the reason for that is we want a facility-specific antibiogram because, and I'm going to use urinary tract infections for most of this because we know they're one of the more frequent infections in the elderly in nursing homes and also the one that's most inappropriately treated. So we know your resident has appropriate signs and symptoms. We've sent a urine culture off. Let's say your provider orders Cipro, but based on your antibiogram, E. coli is 80% resistant to Cipro within your facility. That would not be a good choice as an empiric therapy because there's a good potential that the organism may be resistant and you would have treatment failure. So that's why we want facilities to have and providers to use an antibiogram. It helps them select the most appropriate agent for your empiric therapy. It also helps determine any changes in resistance pattern. And then another piece of the empiric therapy is, do we have the appropriate dose based on the site of the infection and the severity of infection? And these are all pieces of moment 2. Moment 3 occurs at the time the prescriber writes the order for the antibiotic. They have to include in the order the type of infection, the antibiotic being ordered, the dose, a start date, and they must have a written stop date written as a calendar date. In other words, if antibiotics were started on September 11th and it's going to be a seven-day course, that stop date must be, it can't just be written stop at 7 days. It must be a calendar day. Stop date would be September 18th. So it's important, and that is required. That's a piece of what CMS looks for. Another big piece of duration of therapy is if the culture comes back or the x-ray comes back and a specific source or pathogen is not identified, then it is recommended to de-escalate or stop the therapy. If the indication for the antibiotic is no longer there, then the antibiotic should be stopped. And another part with the duration of therapy is we always want them to choose the narrowest spectrum drug that's likely to be effective. Then we get to moment 4. And moment 4 is when we're doing our timeout. It's been 48 to 72 hours since we started the antibiotic. Lab results are back. This is when the resident is reevaluated. The testing results are reviewed, and the nurse has that communication with the provider. We have a negative test result. Can the antibiotic be stopped? Or we have a positive culture, but can we potentially narrow the therapy from what the empiric drug was? Let's say the empiric drug that was started was fluoroquinolone, like Levaquin. We know that's an extremely broad spectrum antibiotic that has a lot of side effects for the elderly. We now have a culture and sensitivity back that shows the minimum inhibitory concentration, or the MIC, of how effective different antibiotics were. Is it possible to decrease or change the antibiotic to something not so broad spectrum? Moment 4 then basically occurs every day when you're taking care of this resident for the nurse or the prescriber. The nurse should be thinking, do we still need this antibiotic? Do we still need this broad spectrum? Do I need to have a conversation with the prescriber to see if this is still continued? Sometimes you may have residents, if it's a severe enough infection, started on an IV antibiotic. Another piece of this is, are we to the point that they can safely be converted from an IV antibiotic to an oral antibiotic? So I just want to go a little more into detail into watchful waiting. Some of you, I'm sure, are very familiar with that, and some of you may not be. One of the most important barriers to overcome when it comes to decision making is inaccurate assessment and diagnosis. And one way to overcome this is to avoid giving antibiotics to residents with very nonspecific or mild symptoms. This is when watchful waiting comes in. Watchful waiting is when you have that resident with very vague symptoms. Maybe they're just not quite as clear today mentally, but that's her only symptom. Or maybe the urine looks to be cloudy or very dark, but we have no fever or any other symptoms. Watchful waiting is enhanced assessment. We don't want to give empiric antibiotic for changes in conditions like a fall or mild confusion if there's no other very specific symptoms to go with it. This is when the resident is assessed more frequently by the nurse to look either for resolution of symptoms and also to look for other causes. Watchful waiting is when you're doing more frequent vital signs. You're doing more frequent assessment of that resident. You're providing hydration in case we're looking at dehydration causing some of these symptoms, such as frequently and urgency and voiding. This is when you also take the time to see, was my resident started on a new medication that may have led to some confusion or worsening symptoms? Watchful waiting promotes assessment and evaluation of the resident and evaluates the changes of those nonspecific symptoms. So as I said, you encourage hydration, you look at the INO, you do more frequent vital signs. If the resident becomes more symptomatic, it's an immediate call to the provider start the antibiotic. But if the symptoms are starting to resolve, then an antibiotic may not be necessary. So we have 5 Ds of antimicrobial therapy. We want to make sure that it is the right drug, at the right dose, by the right drug route, for the right duration of time, and that we are de-escalating it based on our testing, based on our culture and sensitivity. These 5 Ds should be applied to all antibiotic prescriptions. And prescription documentation, including the indication for use, is required by CMS for long-term care facilities. So you have staff, and they all have a role to play in this clinical decision making. The CDC recommends staff be empowered in developing, implementing, and overseeing antibiotic use. Your medical director assists in setting the standards for prescribing practices for all providers and oversees adherence to your antibiotic stewardship program. Your prescribers should have judicious use of antimicrobials and adhere to your antibiotic prescribing policies and antibiotic use. They should also be good stewards by following the 5 Ds for antibiotic prescribing. Your director of nursing sets the practice standards for assessing, monitoring, and communicating changes in a resident condition by frontline staff. Your infection preventionist is your resident expert. They have key expertise and data to inform strategies to improve antibiotic use. Your nursing staff, your RNs, LPNs, and your CNAs all play a key role in decision making for when it is necessary to contact the provider for a potential antibiotic. It is important they are aware of what are considered clinical signs and symptoms and that documentation occurs. Pharmacies have your antibiotic drug expertise and together with the laboratory help develop your antibiogram. And then where it has others listed, the CDC lists that as others who may be resources to use, such as hospital IPs or ID docs that can provide support and information. So there's some tools available to assist you. The first one, of course, is the IPs here at the authority, and this screen has our contact information on it. The second one, this is an example of an antibiotic timeout protocol that was developed as part of our Antibiotic Stewardship Collaborative. Ours is on the left, the Minnesota Department of Health is on the right. Those are both shared governance that can be used for your use, and links to them are under the resource page coming up. We also have SBARs. If you're not using SBARs in your facility to communicate changes in a resident condition, I strongly recommend it. It has the criteria on it. It is easy to see if the signs and symptoms are present for a potential infection to communicate that to the provider. But there's also this wonderful antibiotic decision form that is part of AHRQ's 4 Moments Toolkit. This helps you incorporate the 4 moments. It is a guide that lists what are the appropriate signs and symptoms, same as the SBARs. I strongly suggest that you take a look at any of these tools. These next couple slides are the links to those tools. The links to the SBARs and our timeout protocol are on the first one. The second one is the load criteria and the 4 moments toolkit. The bottom one is a really nice poster for your units on the 4 moments to help refresh staff's memory and provide education. So that concludes my webinar. Are there any questions?
Joanne, we do have one question that came in. What is the recommendation for changing a Foley catheter prior to collecting a urine specimen?
If that Foley catheter has been in longer than 14 days, it must be removed and a new catheter inserted to collect the specimen. That is what was recommended by the CAUTI toolkit developed by AHRQ because of the formation of biofilm. So if that catheter has been in more than 14 days and you're going to send a urine culture, you must remove that old catheter and replace it.
Okay, great. So that does put us at time here. I want to thank everyone for joining us today. If you have experienced any issues accessing the evaluation and/or certificate of continuing education, please feel free to direct any inquiries to Shelley Mixell at shmixell@pa.gov. This concludes our webinar.